Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, colleagues, friends everywhere. It's my great pleasure to be chair of this session on a topic called PCI lift main data evaluation and technique optimization. For that, I think we have a great faculties from Italy, from Saudi Arabia, Emirates, Oman, and myself, Abdullah Shahab from Al Ain, United Arab Emirates, and always great to be a part of Gulf Intervention Society board and to present with my colleagues second, I think, is a webinar episode on a series of sessions we have together. The board of GIS did a great job with the great president we have, Dr. Fawaz al-Mutayri, who put this together to come with a series of meetings together. So for this meeting, we have Dr. Imad Sheban, all of you know, is one of, I call him founder of, international founder for our GIS. Always been with us, and he's a well-known interventional cardiologist. Been, you know, anywhere you go, you find him operating or giving talks. So it's great to have him here with us on a very important topic, left main. And we have Dr. Mervet, Dr. Asima, our panelist is a unique to have a female interventional cardiologist. Rare, but are here. Great to have them with us. Dr. Mervet, all of you know, from Saudi Arabia, director of the Cath Lab in Jeddah. She's highly active in education and her practice of intervention cardiology. And Dr. Asima, my colleague and friend from United Arab Emirates, Sheikh Khalifa, she's a program director for fellowship in cardiology, and she's very active intervention cardiologist. We also have Dr. Abdul Aziz Zaidi from Saudi Arabia, consultant cardiologist, to show us an important case on left main. It will be interesting to see how the normal life, you know, different than what we see in the big conferences. Similar to Dr. Prashant from Oman, colleague from Oman, to share with us his case. So the question is, should we do a PCI for left main? And if we're going to do it, how should we optimize that? And then when to do that, we'll go in details with my colleague and friends, Dr. Imad, to tell us how to optimize that technique with imaging, with functional, and really data evaluation, supporting that from data. Dr. Imad, we are looking forward to your topic, inshallah.
Thank you. Thank you very much for your kind presentation. I am really it is my great pleasure being with you here in GIS webinar, and I think it is still challenging doing angioplasty and left main. And what I'll do, I'll just try to go through the updates of techniques as well as some clinical data as well. So I think first of all, who should receive revascularization? First of all, we should define left main disease before, and that means we should be sure that we are doing correct, the indication is correct. That means left main having a significant stenosis. Then the challenge with left main, what's optimal left main PCI, whether it's one stent or two stent, which kind of stent to use, which approach, simple or complex, and how to optimize both provisional and double stenting as well. So all these challenging are in left main. I would underline again that intracoronary imaging and physiology evaluation left main PCI is very important to define the disease before angioplasty, to guide the procedure accordingly to the anatomy and the distribution of plaque, and then for the optimization during the procedure. That means to have the optimal result at the end of our procedure. And this will guarantee, as we'll see later, will guarantee better outcome in terms of less mortality, less stent thrombosis, less infarction, less target lesion revascularization. So it is very important. In left main, I think we should evaluate, if we pre-procedure, we have to go for both branches with IVUS to define exactly the distribution of plaque, and after this, we can choose correctly which kind of approach we should use. That means how to cover, which is more adequate of these approaches, I mean the technique. And after that, again, completing that and going for optimization. I would say what we have today, we have more data about intravascular imaging by IVUS than OCT, and we have consolidated data where we can really feel comfortable to act on. That means around the size of, sizing, minimal luminal area, and so on, which is still lacking with OCT. But OCT, I say that with the high definition, can be much better for the optimization of the procedure because of details you can get from this kind of procedure. You'll see exactly your stent, the struts, the distribution, the orifice of side branch of the branch, and distal left main, as well as even the passage of guide wire where it is proximal or distal, or if there's some deformation of the stent after after deployment. And of course, you'll give you the exact picture of the carina, and this will help much in optimization of the procedure. We have already many data, but again, I'll show you this recent meta-analysis showing that the IVUS guidance as compared with angio-only guidance will do much better in terms of reduction of death, reduction of myocardial infarction, reduction of stent thrombosis. That means, again, all these studies you see here taken in this meta-analysis there was a concordance that all these important parameters can be improved by using intravascular imaging. And now we have also consensus coming from European Bifurcation Club and most expert in intravascular imaging around how to do and how to evaluate pre-procedural as well as the optimization during the procedure, both with IVUS or with OCT as well. So all these data are there, and I think we should take care and understand exactly what we are doing every time we are approaching left main in these patients. About how to select the procedure, whether it's simple stenting versus complex stenting, I'm sure that I'd say that Medina classification is not adequate for this. That is because there's a lack of lesion characteristics and severity of lesion, side branch size and lesion length on side branch, the angle, the presence of calcification, tortuosity, thrombus. So all these important data cannot come from Medina classification. Medina classification is an excellent classification, simple for defining plaque distribution, but I am convinced that it is not to be used to guide the strategy selection in distal left main. Just to give you an idea about what I am saying, you can see here Medina 111, both are 111, but I'm sure you'll agree with me that strategy in this patient on your right will be different from this patient on your left, because distribution of plaque is completely, of disease is completely different, diffusion of disease as well, and of course the carina also is completely different. Same also in this case, you see very complex anatomy here, and here simple anatomy with might be with simple stenting also, and both are defined 111 Medina. So 111 doesn't mean every time that you should go for complex stenting. It is generally accepted that almost 70 to 80% of cases are simple bifurcation, also in distal left main, and can be managed by single stenting. And in the remaining 20 to 30% of cases should be the default strategy should be complex stenting. But what is the undefined issue is still what is complex and what is simple bifurcation lesion. This is important, very important issue, and we should have a universal definition that put in agreement, me and you and every operator. That means the meaning of complex should be universally accepted by all, as well as for simple bifurcation. And this is very important because if you are shifting from simple bifurcation to complex bifurcation, that means provisional two-stent technique, then your procedure will be associated with higher MACE. That is why it's very important to define the complexity of lesion before and to start with the default strategy, the elective strategy for the tailored for that patient, whether it's, if it's complex bifurcation, do complex stenting. If it is simple bifurcation, do simple stenting. This is coming also from definition 1 study where complexity was defined with 2 major criteria, mainly by the length of lesion on side branch and other minor criteria, which is multiple bifurcation, thrombus containing, main vessel, the diameter less than 2.5, that means small main vessel, lesion length on main vessel, it's 25 and so on. So these are the minor criteria, but major criteria is almost defined by the length of lesion on side branch, that means more than 10 millimeters will be complex. And see what this important data, because if you are going to do simple bifurcation in 2 stents technique, that means complex stenting, then the outcome will be worse than as compared to provisional stenting. Vice versa, if you are doing complex stenting as defined by definition criteria with the simple bifurcation, provisional stenting, then the results, the outcome will be worse than 2 stents. This is the only stent, this is the only study, I would say, that showing that at least in selected patients in complex bifurcation, 2 stents are doing better, significantly better than 1 stent. And this is confirmed by recently published in European Heart Journal, again, the definition 2 study, comparing provisional and complex stenting in complex bifurcation lesion. And many of these patients were distal left main bifurcation. And again, complex stenting done with provisional will do worse than 2 stents. That means 2 stents is the elective technique for complex bifurcation lesion. The main thing is to be to agree all together that what is complex and what is simple. Now, about technical issues, I think today we all will agree that provisional stenting should be simple. That means you will predilate when it's necessary, you will put your stent, you will pot, that means inflate a larger balloon in the proximal part of bifurcation. And if you do not have any compromise on the side branch, then your procedure is finished. And you do not need to go for kissing balloon inflation every time. But if you have some compromise, then you should cross appropriately the stent to side branch. That means try to cross distally, then do kissing balloon, and after you are doing kissing balloon, I would recommend again to repot again and finish the procedure here. If you still having some compromise, then shifting to complex stenting should be the rule in these cases. Pot, I think it is not necessary to go in detail, but I think it is very important, particularly in left main, because we have a mismatch between the diameter of left main to the diameter of both circumflex and LID, and this might go, if we are choosing our stent accordingly to the diameter of left main, might lead to a shifting of carina, while if we are choosing that accordingly to the distal main vessel, that means LAD or SIR, then we can correct the position, the stent position in lift main by POT. And this is why POT is very important and should be done every time we are doing lift main. Keep it simple every time you can do it. I mean, in this case, you see that carina, it's almost not involved. And if you document by IVUS that it is what is you are seeing in angio, it's also seen on IVUS, then I think you don't need even to cross over. You can just stop with your stent at the carina. This will be the final result, and the patient will be doing very well. And of course, you will have less MACE on the follow-up. The other important problem in provisional stenting is the side branch. What happened on circumflex when you are crossing to LAD, for example. Sometimes you will have some compromise on circumflex. Don't hurry up to put another stent or to shift to complex bifurcation stenting, because I think it is very important to go for functional evaluation. As in this case, you see that FFR is 0.80. Something should be done here because we are dealing with main vessel, that means circumflex. Then if it is carina shifting, just it is enough to inflate a larger, small balloon to enlarge the strut and to correct the carina shifting, and this will be coming back to normal FFR without doing any other thing. And this patient was performed like this without putting another stent, and he is still doing very fine even at 8 years after the procedure of in this case. Every time you are dealing with lift main stenting, that means particularly when you are covering the whole lift main with stent, I think other important complication can be coming up by the longitudinal crush distortion of the stent, or crushing longitudinally the stent, and this can happen by sucking the guiding catheter when you are retrieving your balloon after stent deployment, or if you are jailing wire and retrieving the jailed wire, then the guiding catheter can be sucked into the lift main and can crush the stent, and this can of course compromise the outcome, and it is not every time easy to correct this situation. About kissing balloon inflation in provisional stenting, it is not always recommended. I think should not be done if it is not required, and even it could be even harmful. In some study was coming up that it will increase MACE on long term in provisional stenting if it is done without any necessity. Alternative to kissing balloon, I think the POT, as we have said before, or side branch if you have some compromise, and then after that side branch inflation, and then followed by POT, that can be an alternative if you have some compromise on side branch. What about complex stenting? I think just to summarize, because we cannot go in details, we can discuss later on. To summarize what is complex stenting, I think we can divide it in 3 families. The T stenting family, which is including any modification to T stenting, and I will include tap or reverse tap in this family. That means it is T stenting, modified T stenting. Then crush stenting, which is conventional crush is not anymore done. What we are doing is mini crush, or alternatively, we are doing DK crush today. And culotte, again, culotte, who is doing culotte, trying to a minimal overlapping of 2 stents in the main vessel every time. So we are going more for mini culotte than the conventional culotte as it was described before. And of course, each technique need to be performed step by step, and each technique should be optimized of course, if you are doing lift main, I think it is quite mandatory to have intravascular imaging every time you are putting two stents in lift main. That is true for any of these techniques you are doing. Which is the preferable technique? I think it depends on operator experience. If you have more confidence with one technique, you should go with that one, where you know that you can have a complete control on the technique, as well as you can optimize your technique because you have more experience in that one. But in the meantime, one single technique cannot be appropriate for all patients. Then you have to know that you can have an alternative to your preferred technique. We do not have data, just small data coming from DK crush studies showing that DK crush can be superior to Colot or to provisional, but I think it is not enough to change our habits today. We need more data, because these studies are coming from a center who invented the DK crush. Then we need another study without any bias that confirming these data again. What is surprising that European guidelines are indicating now, only based on DK crush data, to prefer DK crush over provisional or T-stenting technique, particularly in distal lift main. But you see, the class is 2B and with level of evidence B. I think that it is important to show the DK crush. DK crush, of course, have some advantage over mini crush or conventional crush, but should be done step by step. In this case, you see the first dilatation by balloon, of course, pre-dilatation. IVUS assessment is very important to see where you have your plaque, I mean the distribution, and how sizing the stent, and again choosing where you have to crush the stent, whether from LAD or from circumflex. This is the first step. That means you are stenting side branch with a balloon in main vessel. Then second step is, after you have stented side branch, you will crush the protruding segment. You should try to minimize the protrusion in main vessel. Crush that with the balloon already present in lift main, in main vessel. After this, rewiring to side branch, and you should try to rewire proximally, because this will avoid crossing beyond the stent if you are crossing distally. And when you are putting a balloon and inflating a balloon, you might crush again the stent on the ostium on side branch. So if you are crossing from this side, you have the risk to cross outside of the stent with re-entry in the stent, and this can complicate your procedure. So try to cross the stent proximally in proximal part. This is when you are crossing proximally. Then this is the first kissing balloon, which is this is the difference: recrossing and kissing balloon as compared to conventional crush. That means this what adding more 2 steps to the crush, to conventional crush technique. After this, main vessel stenting, recrossing again to side branch, spot inflating the stent in lift main adequately in order to avoid the passage of wires outside of the stent. And after this, rewire back side branch, and sequential dilatation on both side branch and main vessel. And after this, the second kissing and final 7th step, final report, and final result will be like this, optimal final result. Of course, this kind of crush will avoid having 3 layers of struts in front of side branch or circumflex ostium, and I think can also ensure more adequate expansion and coverage of the osteum of circumflex. And of course, IVUS control after all these data will be essential. Now, finally, I'll come to some clinical data. This is the trial, I think, known to all of us, which is syntax trial that changed our practice. That means followed by all these studies till 2014 and meta-analysis, all results were in concordance that stroke is higher in surgery group, TVR is higher in PCI, outcomes of PCI with drug-eluting stents is comparable with surgery in the low and intermediate risk patient, syntax score patient, and surgery is superior in patient with diffuse disease. And this changed also the European guidelines, and now from 2014, you see that left main angioplasty will pass through class 1 with evidence-based. And following this, Excel and Nobel came out, and with divergent data. So many analyses, many other studies have been done from 2016 to 2020, 355 publications about comparing PCI to CABG, about techniques, about outcomes, intravascular imaging, and so on. Mainly, I'll not go through all these results, but I'll show you again that all these meta-analysis and randomized studies came to the same conclusion, that no difference in mortality between the two treatment strategies. Meta-analysis, including syntax, pre-compact, and other Nobel and Excel as well, show no difference in safety endpoint. In patients with high-risk anatomy with left main and multivessel disease, surgery is clearly the better strategy with superior long-term outcomes. Patient with low and intermediate risk anatomy, that means syntax score less than 32, either PCI or CABG, can be reasonable with PCI being associated with less morbidity, hospital stay, and lower stroke rates in the peri-procedural period, but with higher target lesion revascularization over time, despite the use of second-generation drug-eluting stents, intravascular imaging, and optimization technique. And it is very important, this publication coming just 2 or 3 months back, showing from Excel study, showing that the mortality, all causes for mortality at 3 years, it is not different between CABG and PCI. What is different that both groups repeat revascularization will be associated with more mortality. So what we should try to do is to reduce repeat mortality, whether with surgery or with PCI. And left ventricular function as well, it is impacting the prognosis in these, particularly in severely compromised left ventricular function. These patients, independently from technique, that means surgery or angioplasty, will have worse outcome as compared to mildly or normal left ventricular dysfunction. And there is no, you see here, there is no difference between surgery and angioplasty in terms of the impact of left ventricular dysfunction. About 10 years outcome, this is a study coming from our group and showing that left main itself is not affecting the outcome. What is worsening the outcome is progression of disease on other vessel rather than left main itself. And again, this also is confirmed by 10 years outcome coming from Azan Center in Korea. What is very carefully, we should observe carefully, is this, the syntax trial at 10 years, where mortality in high syntax score patient is increasing in PCI group as compared to surgery. So mortality is higher in these patients. This is another recent study showing that the only thing at 10 years is still the difference in need for revascularization between surgery and PCI. There is no increase in mortality at 10 years, no increase in myocardial infarction, no increase in stent thrombosis or difference with graft occlusion. What is still there is the need for revascularization is higher in angioplasty group. And this is, you can see that in diabetes, there is no difference in the outcome. That means the need for revascularization between PCI and surgery. And also in syntax more than 23 at 10 years, the curves will be converging, and the difference will be less in terms of MACE at long term. So what is changed from in the guidelines today is that still having the same class for surgery and angioplasty for left main, distal left main. Now the evidence is A for both. Now we have intermediate class with evidence 2A, with class 2A with evidence A. That means some improvement also in evidence that angioplasty in intermediate syntax score patient is competitive or competitive with surgery. What is should be underlined that high syntax score, the preferred and first choice technique should be surgery, not angioplasty. So my final remarks is that angioplasty is a safe and effective treatment for distal left main disease in patients with low and intermediate syntax score. That means selection of patient is very important. Intravascular imaging and functional evaluation are crucial in having good outcome in these patients. In simple left main bifurcation, provisional stenting, as in any other bifurcation, is the default strategy. While if you have complex bifurcation, that means I would say long lesion on side branch or long lesion on CERT, you should go for double stent, complex stenting. Whatever you are doing, you should do it step by step, and you should also be sure that you are optimizing every step you are doing in your complex procedure. And trials and the meta-analysis provide high level of evidence that on angioplasty. And again, the key point is not left main itself, but the extension of coronary disease, and patient with multivessel disease, particularly with diabetic patient and high syntax score, should clearly be considered only for surgery and not for angioplasty. Thank you very much for your attention.
Excellent, outstanding, Imad, as always. Thank you very much. Dr. Mirbat, Dr. Sima, can you unmute yourself? And I'd like to, in 8 minutes coming, to have your insights to this presentation. Please, Dr. Mirbat, you can start.
So thank you, Dr. Imad. It's a very thorough presentation. I think if from practical point of view, there are several points that I'd like to mention. I know the bulk of the studies that were published and that we based guidelines on in our practice actually depend on the syntax score, but unfortunately the syntax score is an anatomic score. It doesn't take into consideration the clinical parameters of the patient. So irrespective of the syntax score, if I have a patient who is high risk for surgery for whatever other comorbidities, pulmonary hypertension, prior strokes, etc., then the guidelines are different, and the heart team decision has to be different, and engaging the patient and the patient preference has to be different. And I don't think the uptake of the new syntax 2 score in a lot of centers and in clinical practice has really taken up significantly, but we really should be taking that into consideration and to remember that the syntax score is strictly anatomic. I completely agree with you that operators should be comfortable with a technique, a bifurcation technique. I think that in order to do, particularly left main, left main per se is a large vessel, and the PCI may even be simpler than some of the other complex, the more distal vessels, such as like a tortuous LED diagonal or something. But the territory that it covers is large. And therefore, the operators have to be skilled. You have to have the backup. I mean, you have to have the proper setup. I don't recommend doing left main PCIs if you do not have a cath lab that has intravascular imaging. I do not recommend doing left main PCIs if you don't have on-site surgeons. It can be simple, but when things go wrong, they go wrong quickly. 99% of our left mains we never need the surgeons for, but in that event, 1% that you do need them, it's wise to do it when you have on-site surgery and not working in a cath lab that doesn't have that. That would be my second point. And my final point is that, we recommend that operators get comfortable with the technique because there are fine details, where you cross. So in DK crush and tap, you don't cross the struts in the same, one is proximal and one is distal crossing. So unless the operators are comfortable and actually know that, then they shouldn't be doing it. And I don't think there's anything wrong with actually referring it to a tertiary center or to someone with the appropriate expertise and the appropriate setup. So, if you have someone with the IVUS or OCT with surgical backup and so on, it may not be wrong to do it, just like we do for structural heart. So if you have a program for mitral clip, for example, then refer to a center with mitral clip and mitral clip expertise. I would say the same with respect to the left main.
Well, great comments. I totally agree with you. I'd say that high syntax score, now we have some data. Syntax score is anatomical characteristic only, and I agree with you. Some patient will not have the same outcome because of comorbidity. And we have some data coming out now that showing that high syntax score is not doing that much good with surgery as well. Particularly in diabetic patient, particularly with more than one comorbidity. This is your first point. The second point, I agree about techniques. I think intravascular imaging should be available in the cath lab where you are performing left main angioplasty, because left main angioplasty, if you have some complication or let's say like thrombosis, that means you will lose the patient, and we cannot do this. I mean, in any patient, we should keep safe the patient. Whatever we are doing, we should keep the safe, and this can be done only if you are doing optimally what you are doing. So I'd like to thank you about these comments, because I totally agree with you.
Yeah, we have also. Yeah, go ahead.
No, and again, to approach left main, I think it is not for beginners. Left main angioplasty is not for beginners. I think you should be trained. You should have an expert in your cath lab when you are starting with your left main program. And again, I totally agree. Surgery on site should be there every time. I mean, as in structural interventions. Great.
I mean, I think Dr. Mervet and yourself addressed most of the question we received from the colleagues and comments about on-site surgical backup, about the imaging, about just going beyond the syntax, because we have syntax 2, then we have extend, which is 10 years. So I think these scores are important for our, to consideration when we come to the left main PCI, because you've seen cabbage versus PCI. We're still, one green. Still orange and red, still not reaching not competing with a bypass. So Seema, can we hear your insight to this, please?
Hi, everyone. I think I totally agree. I think one thing when we see these studies about how left main stenting, the outcome is very good. As interventionalists, we get really excited, but we have to remember that these studies were done in centers where we have operators that have a lot of experience, and they're not doing these ad hoc. So I think for left main stenting, unless it's an emergency, it should not just be done ad hoc. It should be sort of a team discussion. and also gain as much experience as possible. And the studies are good, but you need that experience before you go ahead and start with left main stenting. In terms of imaging, unfortunately, in some countries, they don't have IVUS or FFR or anything. So it's a limitation, and we just have to do with what there is out there. And also in terms of on-site surgery, not all hospitals have on-site surgery. So I think, again, it depends on the comfort level of the operator and the experience of the operator in terms of how they're able to handle if they get into problems, things like that. But again, it should not just be done ad hoc.
Great. I think beautifully addressed this presentation. Now, we go to real life, okay? So we hear beautiful presentations and the conferences, where you see the high tech and things, and real life tell us something different. We have two colleagues here, one from Saudi Arabia, one from Oman. Dr. Abdulaziz is going to share with us an acute case. Then we go to the elective case. Dr. Abdulaziz, looking forward to your topic.
Okay, thank you very much, Dr. Abdullah.
Can you unmute yourself?
Alert from Clean My Mac X.
Okay, do you hear me?
Yes, we hear you.
Okay, great. Thank you very much, Dr. Abdullah, for this nice introduction. I will share the screen now. Okay, so my case today is a patient with left main coronary artery thrombosis in a setting of acute coronary syndrome. He's a male patient, middle-aged, with the usual risk factors: hypertension, dyslipidemia, diabetes, ex-smoker. He had a stent to his proximal LAD 7 years ago, presented with non-STEMI. His ECG was unremarkable, and the echo had anterior hypokinesia. In terms of his lab test, he had a positive troponin. His LDL and HB1AC were high. I took him to the cath lab because of the history and the presentation. And I went through the radial approach, which is I use more than 90% of my cases. And I think you can appreciate that when you start looking at the left main, there is a filling defect in the distal left main. Then you can appreciate that there is a stent in the proximal LAD right here. I'll go to the next view. Again, in this view actually is a little bit misleading, because you would think that the stent is in the left main, but it's not. The left main ends up right here, and the stent is in the proximal LAD. And you can see and appreciate there is a significant long lesion in the LAD at the first diagonal bifurcation, which is involving the ostium of the diagonal, which is a disease itself. In terms of the circ itself, I don't see any flow limiting lesion in the circ. Again, you can see this, it's a little bit crowded tree here, but you can still see that filling defect in the left main. In terms of his RCA, it looks anomalous actually. Probably the takeoff from the sinus, left sinus. It's a little bit tortuous, dominant vessel, but no flow limiting lesion. You can see it here again. So to summarize, here's the patient with the distal left main disease, thrombotic disease, bifurcational LAD lesion. The stent itself had probably 30% in stent restenosis, and this anomalous origin of the RCA. What would you do now? So my initial management was, since the patient is clinically and hemodynamically stable, I thought to use the glycoprotein 2B3 inhibitors for at least 48 hours. So I put him in agrostat. And my plan, of course, to repeat angio and to see if there is any resolution of that thrombus. Unfortunately, there is no other imaging modalities available. And the question, of course, what would you expect now? Unfortunately, nothing has changed. The thrombus still there, the filling defect still there. And then I tried different views, still I can see it there. Again, the same thing here. It's a large system, large lift system. So since the core angio showed no change, I immediately discussed the case with the cardiac surgeon, who of course accepted the case for CABG. And then when I talked to my patient, he totally refused the idea of CABG. And he said, I want the same procedure what I had 7 years ago. So I had to let him sign a high-risk PCI, and I requested the cardiac surgery to be standby, actually. Then I went this time from the femoral approach with 7 French teeth, just to feel a little bit more secure about if there's something, if something goes wrong. And I wired both the LAD and the circ. And then I went with the stenting of the left main, because I just want to make sure that this left main opens. So I put the stent in the left main and overlapping with the previous stent in the proximal LAD. I inflated briefly to nominal pressure. Blood pressure went down, of course. But then things went back to normal. He regained normal blood pressure. At that stage, I was happy that there is no black shift to the circ. I went and then exchanged my wire from the circ to the diagonal. And then again, direct stenting. I like direct stenting. And put a stent, which was, by the way, the stent in the left main was 4.5 by 18. This stent in the, I'm sorry, it's 4 by 18. The stent in the LAD is 275 by 26. Inflated with the gelled wire in the diagonal. It looks okay, needs more work. Then I withdraw my gelled wire from the diagonal and put another inflation up to 15 atmosphere. It looks fine to me. At this stage, I felt that everything is open. There's no black shift. I just need to go and optimize the stent in the left main. So I went with the 4.5 by 8 non-compliant balloon with nominal pressure. Again, it looks good. Happily, there is no black shift anywhere. The patient is doing fine. No complaints. So just to summarize what I did briefly, femoral approach with 7 French. I used the ABU, by the way, guiding catheter 3.5. Wired both the LAD and the circ, direct stenting to the left main LAD with 4 by 18 millimeter stent with nominal pressure. Then exchange the gelled wire from the circ into the diagonal, direct stenting to the LAD with 275 by 26 millimeter to nominal pressure first, then remove the gelled wire from diagonal. Then again inflated the stent LAD up to 15 atmosphere. And finally, post-dilatation of the left main LAD stent with non-compliant balloon 4.5 by 8 millimeter to nominal pressure. And this is the final result. Patient again was doing fine. Actually, in the weekend, I called him and he's doing great. And that's it. Thank you very much.
Great, Abdul Aziz. Excellent presentation. And so acute, Dr. Imad and Dr. Asima, Dr. Mirvet, any comment on this case?
Yeah, so, just please go ahead.
So thank you, Dr. Abdelaziz, a very nice case. I think perhaps I'm just going to break it down for some of the fellows and the participants. I think it's usually wise to start more distally with the intervention and then move back. So conventionally, we would be starting with the LAD and the diagonal, and then moving back and doing the left main PCI in order to not inadvertently cause compression of the left main stent. So that would be point number one. Sometimes you can't do that. Sometimes if there's critical disease in the left main, you have to secure it. A lot of the times I won't deploy a stent. I would dilate, proceed with the distal intervention, and then come back and deploy the stent. Point number two is when recrossing, I try to do optimization and post-dilatation so that my wire doesn't go behind the struts. So that would be a point about trying to dilate as best as possible before recrossing. And my final point, and this is once again not for expert operators, it's just to kind of break it down for fellows in training, is when we are trying to recross into side branch, we try to go distally into the main vessel and then kind of pull back and recross so that we know that we are within the lumen. Of course, we try to use intravascular guidance, ultrasound for guidance as best as possible for our final result. I think those were the most important points that I sort of wanted to say, and then I'll leave it to Dr. Sima and Dr. Shayban.
So Dr. Imad, Dr. Sima, there's a questions on this case about the use of 2B3 inhibitors. I mean, do you use with the normal heparin doses, or I mean, is that we didn't hear from Dr. Abdelaziz. What dose of heparin you used, or you continued heparin after agrostat, or?
The patient was, of course, in the dual antiplatelet therapy. After the cath lab, he was only in the GB2B3 inhibitors.
Right. Okay. Dr. Imad, your comment on the case?
Yeah. Again, it's excellent case. Very good presentation. I would say about inhibitors we are using when we have a thrombus, evidence of thrombus in coronary, we are using inhibitors every time we're having the doubt that we have a thrombus there. My concern is about stenting directly with it on the thrombus, because many times you might have shifting of thrombus to the side branch, or again you will have reversal of thrombus inside the main vessel after stenting. So I would advise, if you are sure that there is thrombus, I will suck the thrombus with thromboaspiration, mechanical thromboaspiration. That means by, it's very simple to do, it's very short to do, but at least you can remove some part of that thrombus and avoid embolization, as well as shifting to side branch, as well as protruding again back inside the main vessel. This is just a concern about, in general, the presence of when you are stenting with thrombus inside the coronary. I mean, in this subset of patients, that means in emergency situation, I think surgeon even do not have time to go for surgery if you have the consequence of, I mean, you don't need even to ask the consensus of patient, because if he is coming back with cardiogenic shock or pre-shock, I think you should go to do something as quick as possible. And of course, angioplasty is quicker than surgery and less invasive for patient.
If I may just respond, in terms of the thrombus, aren't you worried about disintegration of the thrombus and then causing emboli to the brain or even to the coronary tree?
Unmute, Dr.
Is it a question?
Yeah, I think Dr. Abdelaziz is referring to the data about thrombectomy devices causing increased risk of strokes. But I actually agree with Dr. Imad. In some cases, I find thrombectomy very beneficial, especially when you see this large clot burden, because a lot of times when you're very lucky, I think, but a lot of times when you actually deploy your stent, you see a little hazy part of the thrombus within the stent, or it embolized distally. There was data about use of filter wires as distal protection, but the data for that also is not great. But I think thrombectomy, generally in this part of the world, I'm sure Dr. Abdullah Shihab sees that we see a huge burden of thrombus, and we tend to use thrombectomy devices, not in all cases, but in cases where you worry about disintegration of the clot.
Great.
Exactly. Just final comment. Exactly what have been said now, that thrombectomy is not for all patients. Only when you have huge thrombus inside the corner, like in this patient, I think could be beneficial. Yeah, and studies around are taking in consideration a mixed population. You cannot conclude from that. I think in some patients it can be beneficial, still being beneficial. Thank you.
Thank you. Thank you. Okay, we'll go now to the another case from Oman. This one is a selective case, and it's got a really nice journey with this one. Dr. Prashant, we're looking forward to your topic, please.
Yeah, sure. I'll just open my presentation.
You open your presentation?
Yeah, it's opening. It's opening.
So just while we're waiting, I think another option is deferred stenting. So if you are able to establish flow, what we can do is place patients on antiplatelet therapy and then bring them back for a relook. It may be safer and it may not completely resolve the thrombus, but at least reduce the burden somewhat and permit a safer intervention at that point.
Well, this could be true not in left main patient. I think left main patients are on high risk. If you don't have a good result with inhibitors, I think patient can have some complication over the night. I mean, and you have to hurry up to go to cath lab as soon. So I think for left main, it's better to do something immediately, because patient is still on risk every time you are leaving him with thrombus inside.
Prashant, we don't see your presentation.
Yeah, now?
No, we don't see it. Can you stop sharing and share again?
Okay.
Stop sharing and share. Share again.
You should open the PowerPoint.
Yes, okay.
Yeah.
Make it bigger and go ahead, please.
Yeah. I'm doing that.
Great. Please.
Okay.
Can you
so here I have a patient elective. Unfortunately, I'm sorry that again, IOS catheters were not available. Intermittently, we don't have that. This is a 76-year-old female diabetic and hypertensive presented with exertional angina. Her other unrelated issue was an ECG showing a bifascicular block, RBBB, PR prolongation. Later, she went into a complete heart block and a DDD pacemaker. So her echo was good LV function with diastolic dysfunction. In view of her elderly age and preference, we planned for a PCI. But when she came for the PCI, she was in complete heart block. So we have to put a temporary pacemaker for that. Her RCA was absolutely normal, large vessel, and here there was a tight ostial lesion, 95% circumflex, and left main angiographically appeared okay with subdistal tapering, and ostial LAD also appeared okay. So what strategy? This was our discussion, what exactly to go ahead with this. So as Dr. Iman said, initially we planned a provisional strategy. So TPI was inserted and right femoral approach, 7 French sheath. And this was the ECG when patient came, and we did the ballooning of the circumflex ostium, left main and ostium with a 3 × 15 at 14 atmospheres. and then a 4x23 drug-eluting stent at 16 atmospheres, covering from the ostium to the ostial circ was deployed without any issues. And the part was done with a large balloon 5. Since IOS was not there, we prefer to go for a higher balloon size, and 5x8 at 14 atmosphere, and LED was recrossed with pilot 50 and dilated the struts, and then simultaneous kissing was done with 2 balloons, and again repot was done as per all the steps for provisional stenting. And the left main circ stent was very widely open, dilated, but there was significant pinching of the LED ostium, but there was no dissection, TIMI3 flow, and patient was not having any symptoms, and we left it at that and planned once IOS catheter is available, we will have a relook. But within a month or so, she again came back with recurrence of her angina, and now there is instant stenosis, 95% at the ostium, and also the ostial LED is significantly stenosed. So now the question was what strategy to go ahead, whether reverse crush or a culotte or a tap. Then I preferred a tap technique for this. It was dilated initially, the instant restenosis, and again, unfortunately, DEB was not available. So 95% the lesion was opened up, and then took a balloon to open up the struts of the previous stent and the ostial LED, and then 2 NC balloons were taken. 1 NC balloon was taken and opened, then took the stent. So positioning is very important here, around 2 millimeters inside. So you position the NC balloon first in the left main circ as a marker, as well as for kissing later. So then this LED stent was taken and placed. If you protrude more, then you have to go for a crush technique. If you protrude 2 less, you will miss the ostium. So around 2 millimeters. Then the LED stent was deployed at nominal and then deflated and pulled back for the kissing. So at 12 atmosphere, each kissing balloon was done, and this was the final result, which was acceptable. Circumflex stent was okay. So already I had done a lot of, it was done a lot of pot, and it was widely open. I didn't go for another pot in this case, as I was thinking that again, patient may have instant restenosis, because there is some data that over-dilatation also more than 20 atmospheres is known to cause endothelial injury and vascular smooth muscle overreaction and ISR. And this patient came with a very early ISR. So that was the final result, and
excellent.
She's doing well. Thank you.
Great, thank you very much. So Dr. Imad, Dr. Seema, Dr. Mirvet, your comment please on this case. Maybe
Well,
start with, yes, go ahead.
Actually, this is very challenging, because you have already a stent in left vein, and the patient is coming back with instant restenosis very early. I think you should, again, unfortunately, in your cath lab, you do not have IVUS, but I think the first thing to do, IVUS or intravascular imaging, in order to just to try to understand why this patient came so quickly back. What I would suppose is that if you are over expanding your stent at very high pressure with a larger balloon, it depends on the kind, the design of the stent. You might have damage of the coating of the stent, and then a part, particularly the ostium of circumflex, can be can have the same outcome as bare metal stent if the coating is damaged. And then patient can come back within just 4 weeks. Traditionally, what happened with Yeah, with BMS. The second is that you might have damaged the stent by over expansion. Third, it could be some abnormal reaction of the patient. That means very quick in-stent restenosis. But I would suggest I'll be more supporting the hypothesis that some damage on the stent have been caused by overexpansion. This is first comment. Second comment, that means intravascular imaging to understand what is the cause of in-stent restenosis. And the second comment again about the technique. I would underline that if you can avoid to have too much layers of stent in left main, you should avoid every time this. I think one option you have taken a good option. That means the tap stenting will avoid overlapping stent in distal left main. There are already one stent, and you will have 2 layers, not more. If you go for crush, you might have 3 or 4 layers of stents, and this should be avoided every time. Second option can be that you can tap, that means small protruding from LAD to left main, and only since the in-stent restenosis is focal, you can try to dilate the stent and to use drug-eluting balloon. This is a second option to avoid having another stent crossing over from CIRC to left main. And this gives you a third option. That means if the patient will be coming back again with in-stent restenosis, then you have the option to put another stent from circumflex to left main. So yeah, this is what I can, my comments on. But I think that the choice of the TAP approach is very, the choice of the TAP approach is very, very appropriate here. Again, I would underline that IVUS, it's very important in patient coming back for in-stent restenosis or stent thrombosis.
Okay. I agree, Dr. Yaman.
Only
thing, unfortunately, we didn't have.
Yeah, I know. I understand. Yeah.
Dr. Asima, Dr. Mervet, please.
I think one question I had is after you did the case the first time, did you FFR the LAD? Do you have FFR?
No, we didn't. We have FFR, but I didn't FFR the LAD.
Okay.
Yeah. You see, it's interesting, you know, when you do FFR, even if it's beyond 50%, you get them very normal. Most of the time are normal. But anyway, I think that's interesting to do.
But I think
yes.
One thing,
yeah.
Dr. Iman had pointed out earlier is we rush to stent the side branch, which is in this case is the LAD. But what you did was you sort of just ballooned it and stuff, and it looked okay. But, so I think maybe by FFR it was okay. I'm not sure.
Yeah. Actually, for the recent analysis, is more than FFR. IFR is better for the side branch.
Right.
IFR.
I would be a little bit wary about labeling an LAD as a side branch. I think by convention, we usually go left main into the LAD, and we consider using physiology to determine whether we do need to touch the CIRC or not. But conventionally not the LAD itself, because it feeds the main bulk of the anterior wall. The ostium of the circumflex is actually notorious for in-stent restenosis. And so it is key that the initial PCI, appropriate apposition and expansion, is performed. Granted, intravascular imaging or coronary imaging is not readily available. However, I think the second time around, as Dr. Imad mentioned, effectively this patient earned an intravascular assessment of what's happening. I mean, was it malapposition? Is there a small thrombus that's causing all of this? Is there inadequate new intimal hyperplasia there? So you really don't know, and you will treat each differently for those. I think one more point, and again, this is more directed to fellows in training, is when we decide to do PCIs of the left main, I think if we paid attention to the history, this is a patient who's over 70 years old. And many of us who practice in this part of the world recognize that our 75, 76-year-olds are actually very old, and more likely than not, they will be turned down for surgery. So yes, I would very likely consider a PCI in this kind of a patient. I would try to keep it as simplistic as possible. But upfront, I would seriously consider stenting into the left main and then treating the circumflex, although the disease was in the ostium of the circumflex this time.
Yeah, so before we moving to the audience questions, to optimize the tap technique in this case, our colleague here didn't do the pot. I mean, if you want to do the pot, you have to be proximal where, the new carina are there, because sometimes you do a pot and you distort that. And the other reason to do the pot is to get the flare, of your ostial, left main, because you don't want to have that longitudinal distortion. I think these are important, and always you have this jailed wire there is to help you with not to go. So let's go now to we have lots of questions. We have a question from
no, just one second. The initial procedure, there was a lot of pot. So I was under the impression too much pot is causing a problem.
That's fine. I'm talking about a tap technique.
Yeah.
Okay, if you're going back to, just in general, we have a questions here about the usage of the thrombectomy 2 days after you're seeing a thrombus. Is that any value because already organized? I mean, any comment on that? And left main.
Well, I think, yeah, it have a rationale. I mean, if you can aspirate something every time you are avoiding something that potentially can embolize distally, and many times also with after 24, 36 hours, you can aspirate something, still aspirating something, some thrombus. So I would try every time because it takes just one minute, not more.
Okay. Okay. And maybe comment on the when you come to we don't have IVUS here. Okay, so we have to be realistic here. We don't have IVUS. So how do you choose your balloons for left main? What pressure? Just maybe a quick comment from you guys.
Well, actually, for left main, in my experience, and any operator using IVUS or intravascular imaging knows that left main cannot be under 4.5 millimeters every time you are doing left main. You should keep in mind that left main diameter is more than 4 millimeters. Then you'll choose your stent accordingly to LAD or circumflex, where is your crossover. And then you have to choose the stent that have the capacity to be dilated or expanded without distortion of the stent, and this depends on the stent design every time. And the capacity, I mean, the capacity of struts to be open without fracture of the stent. So these two elements are very important. The choice of a kind of stent and the diameter, every time to choose the balloon for kissing balloon, accordingly to what you suppose LAD diameter and circumflex diameter, and go for selective pot in left main without protruding in distal part of the stent. I mean, with pot, you should keep your balloon at the carina, not protruding in LAD or in circumflex.
So you mentioned many times, Dr. Imad, I mean, this is I want to hear Dr. Mervet and Dr. Seamus comment. Simple bifurcation, complex bifurcation, and then you showed us some criteria. But isn't it, any left main is a complex PCI?
No.
Why do you differentiate?
Well, in my opinion, no, because at least in my experience, and we have seen also some example today, not always you have extension of disease to side, what we consider side branch. That means LAD or circumflex. Actually, if you go with IVUS and you see that no extension of disease to a side branch, then you can be sure that crossover is the default strategy in that patient. If you don't have IVUS and you see that on angio there is no involvement of circumflex in distal left main bifurcation disease, then I will protect the circ with wire and will jail the wire, but in crossover. And if you don't have any damage, any compromise on circumflex, I think it is enough to go for POT and leave everything like that without recrossing to or doing kissing balloon inflation. So this, in my experience, can be done in 60 to 70% of cases, in my experience. Okay. So that means it is, you should try every time to keep it simple in distal left main and to avoid overlapping bulky things, overlapping too much metal at the carina. Every time, even provisional stenting, you should go step by step, optimize your stent, and outcome will be really good.
So the word simple doesn't mean easy. Simple means hard.
Simple,
thing, huh?
absolutely. But, you should do it.
Because sometimes try to explain something to a 4-year-old, to make it simple, doesn't mean easy. It's not very hard thing to do yet.
Absolutely. Simple is referring only to the kind of bifurcation, not for the procedure. Yeah.
Dr. Mervet and Dr. Asima here. Sometimes we get ostial, either LAD or LCX. What should we do? Should we go back to left main, or what? I mean, how do you approach that kind of cases?
So there are many ways to answer that. Again, I go back to what I mentioned earlier. You look at your substrate, you look at your patient, and if your patient has many comorbidities, I usually try to keep it as minimalistic as possible. A younger patient, I'm going to try to, I'm not going to say beautify, but I'm going to work very hard in focusing on all the steps and doing a more complete revascularization in those kind of patients. So having said that, when you look at the osteal disease, you have to know what you have on the shelf. Mm-hmm. So, when you're talking about POT, you have to know what length of balloon that you have to do the POT, the non-compliant balloon. And you have to make sure that your stent is going to cover that segment. You don't want to be dilating, let's say you put a stent, your reference diameter is usually your distal vessel. So if you're going to stent left main into LAD, you're going to use your reference diameter of the LAD, and then you can do proximal optimization of the left main with whatever balloon that you have. But then get a length of the stent for the balloon, the POT balloon that you have on the shelf. There are some 6 millimeter length balloons, but not all cath labs carry those. Conventionally, there's 8 and 12. If you don't happen to have 8 in, let's say, 4.5 or 5.0, then, extend your stent more so that you can get a 12 balloon and do an appropriate POT. Again, if you're going to end up doing something like a TAP, you want to stay clear of that carina, the new carina that you achieved. And so once again, you have to have a length in order to allow you to do proximal optimization. I think one of the questions that came was how high were the pressures that you're going to go up to. So when you're doing kissing, it's really intermediate pressures. I don't go high, but with POT, yes, I am going to go high. And conventionally, I try to do POT way at the end. This is one of my last steps because the new drug-eluting stents, they're wonderful, they're deliverable, but they're also getting thinner and thinner struts, and they're more and more likely to be compressed. So I like it to be the last step that I do, a proper POT, and those I go high pressures.
So one question I have for Dr. Imad, Dr. Sima here, it's important because we are using a stent here. Anything about the stent is important here, the visibility, axial, width, the strength? I mean, what sort of stent we need for left main, please?
Well, I think, of course, open cell stent should be used every time. Second, good radial stress. So these are the 2 components. The design, there is no differences. I mean, in big difference in design, well, the main thing is to have an open cell design of stent. Whether it is cobalt chromium or any other metal, that means should be good. Of course, thin struts are preferred over thick struts.
Dr. Asima.
That means second generation stents all are good to be used in left main. with open stent design.
Dr. Asima, is
I
left,
think
is-
one more thing is if you have a size discrepancy between the LAD and the left main, you also want to use a stent that can be dilated really high in the left main to appreciate.
Absolutely. This is another very important point. The mismatch between the reference diameter in LAD and left main. If a big mismatch, then you should be sure that your stent will be expanded without too much shortening and without deformation of the stent when you are doing pot in main vessel in left main. If it is not, if you are not sure of that, I think you should use different stents. That means stent LAD until the ostium, then put another stent in left main, a larger stent, and you will be sure that you are opposing the stent fully. But this will not happen. I mean, it's not often encountered in daily practice because we have more than one stent over 4.5 diameter can be enlarged till 5, 5.2, 5.4, 3. And now from Boston, we have the Synergy stent for 5.5 stent, which will cover even very large left mains. So this is another crucial point. I agree completely with you.
I mean, the majority of the new generation drug-eluting stents will all expand. So whether you're talking about the Onyx from Medtronic, whether you're talking about Synergy, the majority of them will expand reasonably well. And so you should avoid as much as you can having overlapped segments. But if you do need an overlap, and once again, this is a comment for fellows in training, is avoid the overlap segment being at a critical bifurcation or where an important side branch is coming off. So try to find a segment where it's safe to have an overlap. And since you implanted the distal stent first, you can safely take a bigger stent without concern of having dissection because you're already tacked up distal to it, and then do your proper post-dilatation.
The Excel study, which was 2011, 2014, where, you know, the best, according to the study, stent they use imaging up to 70%. You know, when you sometimes we ask for proctor to come to our country, and they they are expert. They don't use imaging, and the problem here is, you know, Dr. Mervet says the rule of the imaging, but in real life, the uptake of the imaging is like less than 10%. But in randomized clinical trial like Excel, we see it up to 70. So it is mandatory to use, imaging if we want to improve your, your skills. Especially left main is not happening that many in our centers. But those who are like 30 years, like Dr. Imad and Fajadeh and these people. So I mean, when do you use that much? I mean, in your real life, or I don't know. I mean, because I've heard, from experts, they don't use that much because their eyes become like, IVIS.
Well, actually, I would say this. In my experience, I think if you have good experience with IVIS, you do not need to use it every time you are doing angioplasty, because it gives you a feedback, another feedback to look on angio differently. That means that right coronary, for example, cannot be less than 4 millimeters of diameter in normal dominance or equivalent circulation. And same for left main. Diameters, you can learn that diameters and to choose the right stents, the right reference diameter for the right vessel. But I think that even you have large experience, many times you are doing complex procedures, like for example, trifurcation distal left main, you are putting 2 stents. I think it is much safer for patient if you add also intravascular imaging in your procedure in order to be sure, completely sure, that you are doing the best you can do in this patient.
Comment on hemodynamic support, which was about less than 10% in Excel. from Seema and Dr. Mirvet. I want to see hemodynamic usage in left main and also the dual antiplatelets, please. Maybe just to complete everything.
I think with regards to hemodynamic support, for us, it mainly depends on the patient's ejection fraction and also the presence, if the RCA is occluded or not, what the other vessels look like. If he has normal EF, RCA is okay, I don't think there's a need for hemodynamic support.
Yeah.
No, even the BCIS study showed IABP is of no benefit. It's a randomized trial.
Yeah.
Oh.
I'm referring to like Impella and things like that, I guess.
I mean, we're lacking a lot of data to use circulatory support devices, whether it's in the setting of shock or whether it's to use it in CHIP or high risk interventions. But I think we go back again to evaluating the patient as a whole. So we don't look at ejection fraction alone. We look at the coronary anatomy and how complex the intervention is and whether this is the last remaining vessel or not. We see if the patient is in pulmonary edema and their EDP is going up. And their blood pressure is going down, etc. And we see how complex our PCI. And if you're going to do rotablator in patients with very little reserve, you know that any kind of no reflow can quickly spiral down. So I think there are many issues where you would consider circulatory support or not. With regards to antiplatelet, once again, I think we went from an era where we want to give the longest possible antiplatelet regimens, 2 years, 3 years, indefinitely, etc. And now we're seeing a trend where we're balancing ischemic risk against bleeding risk, and a lot of the trials that are either published or in the process at the moment, we're looking at abbreviated regimens, particularly with the newer platform drug-eluting stents. So again, depends on how complex the intervention was, how much stent and overlap there is in the left main. But generally, there's more of a trend now to abbreviate the DAPT regimen.
So first, Dr. Imad and the rest of the colleagues here, I want to say, what about the volume and the operator experience and the volume? The study shows, if you have to do above, at least 15 per year of left main, to get the good outcome. We've seen there are more than 50% of centers and operators that do less than, just above one. So what's your comment on that?
I think there is no magic number about how many procedures you should do.
Quality.
Quality is good. And you have to be supported by some experience, by expert in your cath lab at the beginning. I think you should anyway do at least 10 to 15 procedures a year in complex procedure. Right. That doesn't mean every time should be left main. Any complex procedure can be also a good training for left main disease. Any bifurcation disease, it will be applicable also to distal left main, because all bifurcation techniques are similar. And I think this can keep you trained in bifurcation treatment. This is one. The second is to be aware about the complication can happen unexpected also during left main. So I would advise every time, if you are at your beginning, you suspect some hemodynamic instability, at least take another access to be ready to insert mechanical support if needed. At least the access should be ready, at least.
Yeah. Dr. Amir, any final word you want to say, please?
No, thank you very much for sharing your cases, and thank you for organizing this in the invitation.
Dr. Asima?
No, thank you. Thank you very much.
Thanks for a nice
thank you very much.
Right. I think today was, trying to come to the conclusion that, if we want to do a PCI of left main, we are competing with the cabbage, and we've seen the guidelines. We're still only one green, and still there are orange and red. So precision PCI, I think, is important. We know the advantage of cabbage in terms of revascularization, more complete and less revascularization, and better in terms of the spontaneous MI. But the PCI, when done properly, indicated We have, less invasive, as you know, is less faster recovery and staying in hospital, and less CVA. So I think, as colleague says here, agreed to optimize our PCI and to have imaging from start to the end. Really, I'd like to thank the speaker, the faculty, great faculty we had today, and that we have panelists, female. I think we have more of them, inshallah, in future, and great, cases from the colleague from Saudi Arabia and Oman. And I'd like to thank the GI board and everyone who made this possible, and thank ICOM. Thank you very much, and stay safe.
Thank you. Thank you very much.
Thank you.
Take care. Bye-bye.
Goodbye.